Today, I am very excited to have Dr. Jackie Cruiser. She is Assistant Professor of Medicine in the Division of Allergy, Pulmonary, and Critical Care at University of Wisconsin in Madison. She runs an interdisciplinary research program, and current projects focus on improving the engagement of patients and families in the longitudinal trajectory of care in the ICU, specifically examining the role of time-limited trials as a collaborative planning approach for patients with critical illness. Today, our focus is going to be the language of serious illness, and in particular, considering the word need. I think today's going to be a little more of an interactive format, so please feel free to raise your hand, use the chat, chime in with comments, questions, and I'm going to let you take it away, Jackie.
Wonderful. Thanks so much, Rose, and thanks to all of you for being here and for the invitation. I'm really excited to talk with you about this topic and sort of a focus of our work over the last couple of months. And so I'm going to be focusing specifically on a paper that I had the opportunity to work with two phenomenal colleagues, Justin Clapp and Bob Arnold, and we published this viewpoint in JAMA over the summer. And the focus of this particular paper that we wrote was on the word need and its role in acute serious illness. And through my lens as a critical care physician who practices in an adult medical ICU, I've really been thinking about this word and this way we use language in the intensive care unit and in the critical illness space. I also want to acknowledge Dr. Gretchen Schwarzy, who had a really instrumental contribution to this work as well. And the four of us have really been working on a lot of the intellectual framework that hopefully we'll get into and talk about today. So as sort of Rose mentioned, I just have some slides essentially to lay out our argument and to sort of briefly describe what we said in this paper, particularly for people who haven't read it, and so that we can all sort of be starting from the same place and have a conversation about this language together. And so to need is to lack something essential. And with acute serious illness, almost by definition, particularly for the patients who come to intensive care units, the type of patients that I take care of, lack something essential to sustain their life. So it's at least not surprising to me as a critical care physician that the word need rolls off our tongues as clinicians who take care of patients in an ICU environment. And so examples, if her breathing gets any worse, she will need to be intubated. He needs a central line, a special IV catheter in his neck so we can give him blood pressure medicines. If she doesn't make any urine soon, she will need dialysis. And if she can't be extubated soon, she will need a trach. But the way we use this term can be misleading, particularly when we talk with critically ill patients and their families. And to help illustrate this, I want to tell you a story about a patient that we learned when we were conducting a separate research study. So we were interviewing surrogates of patients who had been in the ICU about a month up to a year after the patient's discharge. And this particular patient I'll tell you about ultimately died in our intensive care unit. And we were asking the surrogates a little bit about their experiences, particularly around the start of mechanical ventilation. And so one surrogate told us her story, and she said she was at home really early one morning. Her mother had advanced cancer, and she was in the hospital on a cancer floor. And in the morning, and these are quotes from the interview, the daughter said, the physician called and said, either your mom needs to be on a ventilator or she's going to die today. And she went on to sort of talk with our research interviewer about what this was like and sort of and how her thought process then proceeded. And she said that her mom kept fighting. She was never going to be put on a ventilator, and that is the worst thing that could possibly happen to her. And so she had described sort of all throughout this hospital stay that her mother had expressed these pretty clear wishes, and her mother happened to have a significant amount of experience in the clinical space. And so this was coming from a very informed place. And then the patient decided, or sorry, the daughter decided to go ahead with intubation mechanical ventilation and said, I trusted the doctors much more than my mom. And so why do we think need, why have we sort of focused on this idea of need? And is it just a simple word, or sort of what does it actually represent? And why do we think it perhaps is having a really outsized impact in the ICU? So if we take a very simple example from a non-medical case, here is a stick figure and he doesn't have any water. That is just sort of a plain statement. There's not a lot of intention behind it. You know, you could potentially read into what I mean by saying that, depending on the context, but at face value, there's not a lot here. But if we take this same person and say he needs water, all of a sudden this is a call to action. And it's not only just a call to act, but it actually labels the specific action that ought to be taken, getting this person water. I mean, look at this, he really needs a glass of water. And so this is really the crux of the argument that we talked through in this paper, is that the word need and the notion, the deep-seated notion of need, creates an inextricable link between the problem at hand and our available medical technology and solution. And so as clinicians, we think about this type of link first. And in fact, perhaps a lot of us are trained in medical school to think about this way. Does she meet the criteria for dialysis, AEIOU, or whatever acronym that you use? And then we take a step back to consider, should we do dialysis? And we may be assuming that patients and families can follow our logic, but as illustrated in the story that I just told you, what I worry about is that after hearing from a physician that the patient needs to be intubated, they assume it's the right thing to do. And then when we set up and start a conversation, even if we were using, say, the best practice of a headline, if we start a conversation and say that, or a particular ICU stay, and say that a patient has a need for a particular life-sustaining treatment, and then we try to walk back and deliberate with the patient or the family about whether it should be done and whether it's best and aligns with the patient's priorities, it at least isn't surprising to me that we often end up in this space of conflict. And so this is what we've suggested as an alternative, as an intentional separation of these two things, with what I view as a relatively simple change in our language. And so instead of saying this patient with respiratory needs mechanical ventilation, we would say the problem with her breathing is getting worse. Can we talk about this, what this means? And so what this means is a signal to patients and their families. And it's really a reminder to us too, as clinicians, because I think we often get caught up in this as well, that the patient's change in health is likely to have a major impact on their future, even if we anticipate a full recovery. And so this intentional pause creates space for reflection without automatically assuming what the next course of action should be. And we also think it's important because this space and this framing allows for space to attend to families' emotional reactions and often distress. This is unfortunate and bad news when we're talking about these sort of scenarios before immediately jumping to solutions or actions. And this is particularly challenging in the action-oriented ICU environment. And so, for example, you might say here, let's see. For example, you might say, I'll wait to get to this, is, the cancer, the problem with your mother's lungs is getting worse. The infection is very severe and the cancer treatment is making it difficult for her immune system to control it. We don't know if antibiotics will help, and I'm worried that she could die. And so, and then separately, you can say, can we talk about what to do next? So this frames separately the opportunity for deliberation. So instead of a predetermined need, it creates a space to talk about what's acceptable and prioritized by the patient. And there's often time pressure in the ICU setting. I know that very well. And so what you say here could be very brief and could happen right outside the room or in the emergency department or sort of whatever space on the phone, whatever space you happen to find yourself in. let's talk about what to do next. We can intubate her and provide mechanical ventilation. It's a form of life support, sometimes called a breathing machine. This will give us time to see if antibiotics were helping. But for some patients, though, being on life support like a breathing machine is not okay. And another option is to provide care that focuses exclusively on her comfort, knowing that she might die from this infection. And so that's sort of the summary of what we've proposed and our alternative solution. But as we talked about in the beginning, what I'm really hoping to hear and have today is a conversation about this. And so I've posed some questions here, perhaps to get us started, but by no means do we have to follow this. And I would really just love to have more of a conversation with the group about, whether you've seen this, whether you've experienced this, whether you're convinced it's a problem, and what kind of solutions that we have together.
Thank you, Jackie. I'm going to be a little bit of a devil's advocate and say I like the word need because it opens doors for palliative care to explain further, but also explain that the goal will dictate the need. And so that patient may, it may be a situation of, I want to get my mom home in the next day or two. Well, if you want to get your mom home in the next day or two, she would need hospice care, and here's why. But, but also you hear the word need in context from patients, and it is a little, you cringe and you're like, well, let's talk about that further. Just another way to look at it.
Yeah, and I appreciate that a lot. And I guess what I would say is, I think that's a very different use of the word need than perhaps, where we were starting and thinking about, which was specifically how the word need is used to link, medical problems with their technological intervention. And I think you're right. And I think you bring up, though, and what you're saying brings up a really important point, is our argument is not to sort of strike this word from the vernacular. And, I think maybe it kind of gets to this idea about, is this sort of nitpicking and kind of patrolling words and just trying to be sort of a definitional police of sorts? And my response to that is, what we really want to do, and sort of our goal with this paper and this conversation, was to not really talk about need, the particular word. We think that's a sort of a vehicle to perhaps talk about how our default language is embedded in our processes of care. And if we study it, or we look at really specific examples, it shines a light on how these embedded and sort of latent processes, like, why is it so easy to always sort of add interventions in the ICU? Why does it feel like that's our default system of care, is really propelling us towards intervening? And all of our work in communication feels like we're trying to undo an understanding that's already taken hold. And so, I think shining the light on this particular use of need helps show how that understanding kind of comes to fruition, and perhaps why we feel like we sort of end up in this conflict space with patients and families unintentionally.
I also think that you make it very evident that every discipline has their problematic words, because of course palliative care has a whole slew of them. But yeah, I think that need in an ICU is a very different thing compared to other places. Just like dying is different in a palliative care world than it is in an ICU world, or a medical floor for that matter. Yeah. Marty, you have your hand up.
Yeah, I have a comment and a question. So about language in general. So when I was reading your paper, I was thinking about language and how in particular we like to either soften certain words or make them more palatable. And I think often in palliative care, we tend to do the opposite of that. We tend to not use the soft word. We tend to use words like dying instead of passing away, or a lot of us stick to our guns and use the word palliative care, even though supportive care is so much more palatable to our colleagues and our patients. But the one word, because I was also thinking, well, what are some words that are still taboo, even for palliative care? And the one word I just don't see anyone use, even palliative care, is the word kill. And I'm not using the word murder. I'm using the word kill, right? So like the act of causing death. And so we use statements like we're removing a ventilator to allow a natural death, or, we're letting the disease take its natural course, or we use other words like medical aid in dying. And I would argue that all of those cases are examples when medicine finds it both ethically and legally okay to kill patients or allow patients to kill themselves, so long as it's autonomous, because patients, they have this right to bodily integrity, and they can refuse any and all treatments that would save their life, and that action causes their death. But I don't use that word talking with families. Of course, it's too uncomfortable. I'm curious to get your thoughts on that. And or do you have particular language, Jackie, that you hear in the ICU that makes you feel uncomfortable, that feels sort of taboo for you?
All right. Well, so I appreciate that you've set up both a very challenging thing to answer, and then you kind of gave me a softball at the end. So I note that. I appreciate it. And I'm going to take the softball first, and then sort of come back to the kill. I will say I haven't really done the intellectual, or maybe I'll comment. I haven't really done the intellectual exercise of thinking of what the benefit would be of using the word kill. I think there's one view, and maybe make an overarching comment about language. I think there's one view of language and sort of how we analyze it. And I've learned this by working with Justin Clapp, who's a linguistic anthropologist, that focuses a lot on sort of definitions and how language represents a particular, how accurate are we being? So perhaps kill is the most accurate word for particular scenarios. And I'd have to sort of think through whether that's true. And so I think there's a lot of conversation around sort of, are we being precise and are we being accurate? And I think our training and a lot of our backgrounds in science and sort of the scientific method and even in medicine, which is really sort of a language-based discipline where we learn our own language and sort of apply it to how human bodies work. There's a real appeal to that, and sort of just that foundational idea of is this accurate and true and precise? But I think, and this is again what I've learned from working with Justin Clapp, is what I think is more helpful, at least in the clinical space, is a more pragmatic view of language. So what does it do? What role is it serving? What effect is it having? And are the sort of effects good or bad or deleterious, above and beyond just, is it sort of true and precise according to, the Webster's dictionary or something along those lines? And I think that kind of, and maybe to sort of bring it back to this need idea, is, I think it is probably precise in some ways to say, this patient with dialysis who meets the indications for with kidney failure that meets the emergent indications for dialysis needs dialysis in sort of some sense of the word. But then when you think about what it does to the system and the context, and the patients and the families, to say we need dialysis and how it creates that inextricable link, I guess that would be my view, and sort of, and how it kind of opens up our understanding of language a little bit more broadly.
As someone who accidentally used the word kill once, it did not land well. But the family was lovely as I walked it back. Yeah.
Yeah, right. And I think my disclosure slide when I talk about this usually says something about how, most of the space that I've done research is kind of comes from, some missteps that I've made or sort of experienced in experience in the ICU.
Yeah. There's a comment. Wait, you guys are good with your comments. Why don't you speak? There's lots here. Okay, so Steve says, reflecting on need, I have less of a problem with the word if we coach it as need to have a discussion or need to make some decisions. And again, that reiterates kind of, it's not the word itself, right? It's the context. Richard says, my thoughts, verbiage is these days center stage in conversational skills development, as is died of suicide instead of commit, and patient with diabetes versus diabetic. Some may be too subtle to affect the reception by the listener. I'm sorry, none of my stuff is working today, so I'm working at this. Being judicious with the word need as proposed is a helpful suggestion. So thanks for the article.
And maybe I'll sort of maybe underscore something in that comment too about, you know, and this is kind of the second question, I guess, that I have up on the screen is like, is this, you know, an over focus and over, you know, an over sort of direction on the particulars of words, and is this just sort of pedantic or academic or sort of too nuanced? But I think the point here made by Richard is exactly right, is that it's not just the direct effect that having, and this is sort of what I was saying a little bit before about how seeing why this language is so pervasive highlights something about the acute care environment that sort of reminds us that we're so that we sort of have this automatic, like, respiratory failure, intubation, you know, renal failure, dialysis, and that, like, by taking the intentional moment to uncouple, perhaps it changes that underlying embedded processes of care that we're often then using sort of downstream language with patients and families to try to undo. So perhaps it's the impact on us and sort of the moment of thoughtfulness and sort of mindful choice in instead of sort of the direct miscommunication that it could have on patients and families. So I like that.
Well, and I think to go along with that, Ashley makes, I think, rather beautifully. I agree with what I think you're saying here. Language is both something that we create and change, and something that creates and changes us.
Yeah.
And then Caitlin, oh my gosh. From my perspective, the word kill connotes, not necessarily denotes, a degree of culpability that one decision doesn't always have, but that family members sometimes take on or assign to one decision, often to their significant distress. E.g., removing a breathing tube may more immediately lead to death, but the overall cause is not that decision as much as it is the illness course that precedes it. But I could also see the use of kill possibly being therapeutic for cases in which family members feel their loved one is making a choice to end their life. And Rachel says, I think this is so essential and makes us aware of the need or opportunity for improved conversation with patients and families. Do you have other examples of trigger words you have observed that providers use that we should be more mindful about the use of with patients and families? Good question.
Yeah. I do. So thank you for that question, Rachel. Another space that I've been really interested in recently, and this one's a little bit more, or perhaps more challenging with a palliative care audience, but we've been studying the phrase goals of care. And it's the tension between how goals of care is described and used in the literature, and often, you know, by our palliative care colleagues, with how it's used sort of more broadly by clinicians and in the ICU space. And, you know, we've done a series of studies now using the electronic health record and talking with clinicians themselves, where we've really uncovered that clinicians, the ICU clinicians in particular, tend to use goals of care as a euphemism for end of life and death. and also as a euphemism to denote conflict with patients and their families. And so I try to avoid in my clinical practice as an ICU physician, I try to avoid goals of care. And I suspect this audience would be would resonate with I'm sure we've all had the stories where I even remember recently where it was a patient with 3 forms of organ failure and an incurable underlying disease who was in the ICU. And I asked the specialist to join us for a meeting with the family. And somehow that got communicated, not by me, because I avoid this phrase, but by sort of someone else, about this was going to be a goals of care conversation. And she said, oh, it's too early for goals of care. And so because the person wasn't sort of actively dying, perhaps, I've learned to just avoid that construct because of the euphemistic nature. And I think there's a whole nother conversation to be had about what that means, that we've developed this kind of two-sided tension. And in fact, in one of our studies, the palliative care clinicians told us that they felt like their role was in oftentimes being sort of the translator, is trying to sort of bring the clinicians to think about the phrase goals of care in the way in which it's described in the literature and sort of the scholarly view.
Steve, we'll have you unmute and ask your question.
Hey, Jackie, thanks for this interesting conversation. So I was wondering if you could comment on whether the way we use the word need depends on the urgency or in the environment. I think maybe need in an outpatient clinic might differ from need in an emergency department or need in the intensive care unit, especially if we couch it around the concept that unless we're told otherwise, we kind of err on the side of keeping people alive.
Yeah.
So,
Right. I think I appreciate that comment, and I think it highlights, I would say there's 2 sides to it. I would agree sort of in general that there's sort of this added sort of urgency and life-threatening nature often about how we talk about need and life-sustaining treatment. So if someone is about to die, and again, going back, so like to need is to lack something essential. And so it is sort of in this very real way that if you lack something essential to sustain your life, that you need that. And so it's a really appealing kind of notion about our particular environment. But I think that there is still this latent understanding about what medicine is for. And it's sort of, as you said, sort of the implicit goals of our healthcare system are to keep people alive. So it's really easy to say, even in the outpatient setting, like, well, you need, you have hypertension, so you need this blood pressure pill. And I think the degree to which that's problematic perhaps depends on the environment, but the degree to which it reflects kind of the underlying and implicit goals of our healthcare system and sort of function of our healthcare system, I think are important, because they help us identify moments in which we have perhaps space to think about alternate goals when, perhaps, cure or recovery aren't possible, or life extension isn't possible as well. But I'm being wordy, and I know we're kind of coming up on time.
We'll try to sneak in 2 more questions, and then we'll let you go. Ashley is next, and then we'll finish with Mary Beth.
Hi, so I am a chaplain, and I'm also not currently working as an ethicist, but I have a background in ethics education. And looking at your second question, and kind of going off of what Richard said earlier in the chat, is about, I think that this is, I would really be curious to hear more about what people say when I'm assuming that you've heard people in response to your article say, oh, this is just nitpicking. I'm curious more about that argument, because for me, I think that our language and the words that we use are beyond important. Drawing a little into the ethics world, there's always the F-bomb, right? And I don't mean the 4-letter one, I mean futile.
Mm-hmm.
And so with that, and then also with what you're doing around need, I'm also curious in like kind of where you see this going next. What other words are you guys looking into and working around in terms of alternate proposals? Thanks.
Yeah, so I appreciate the drawing the connection back to the futility problem. And that's, yeah, I think yet another sort of whole conversation that we could have. But I think it does reflect this history of problematic terms, and perhaps to say something, I don't know if this is controversial, but I think actually what has happened with the word futility is an example maybe of overly focusing on that kind of representational definitional view of language. So I sort of talked a little bit earlier about how we like to think about the pragmatics of language, like what is the language doing and why is it serving this purpose? I think no one really asked that question about futility, and we just kept narrowing and narrowing and narrowing the definition to the point where it sort of can, you know, is only reserved for highly specific scenarios, and perhaps that's appropriate. I'm not arguing that that was the wrong move, but what it has left in its wake is a big gap of other things that people wanted to be talking about when they were using futility. And so I think by forgetting what we leave behind when we kind of narrow the language, I think that's another way that we're really trying to sort of move this work forward, is not just sort of say people shouldn't say need and they shouldn't say goals of care, but why was this so common and appealing? And to sort of have some empathy for the clinicians, instead of just saying like, oh, these silly clinicians, they don't know what they're talking about, they just use crazy words and they're scared of saying kill, or, you know, whatever the and not to sort of, you know, put a straw man to any of the arguments, but like really trying to deepen our understanding about what it is that makes these words so appealing, and why is it that it's hard to say things, and maybe addressing some of those underlying contributors.
All right, Mary Beth, you can finish us off.
Hi, Jackie. I was just wondering if having some of these more thoughtful conversations has affected the clinical momentum for you personally in the ICU, or even like in your clinic, or what you've seen.
Yeah, I will tell you that sort of since we published this article, I've had a lot of people reach out to me and give real clinical examples about how sort of doing that, like changing the word need, changed outcomes. And I'll tell you one story from my practice recently, and then hopefully we'll end on this. So it was an older patient who had cholangitis and septic shock, and had, you know, the family and she were unclear about whether she wanted to go forward with life-sustaining treatment because she was getting pretty sick from this, and yet there was this reversible cause. She had a stone that was causing the problem, and everyone thought it was potentially amenable to intervention. And someone had gone down to the emergency department, one of the specialists, and kind of told the son, you know, if you do this, she's going to need dialysis and her kidneys are going to stop. And, you know, all like if she get, you know, surgery would be terrible because sort of all of these things, she's going to need all of this stuff. But then sort of a variety of conversations happened, and the family decided functionally on sort of a time limited trial to try the procedure and to try to use vasopressors and support the patient. And, you know, by the next day, the son asked me at the bedside, does she need dialysis? And he said, you know, what they told me downstairs is that she might need dialysis. And I said, well, like, I'd like to take a step back and ask like what it would mean if, you know, if she stopped making urine, and what it would mean if it looked like things weren't going well with her kidneys. What that would mean is that this trial of life support wasn't helping in the way we were hoping that it would help. And that would probably mean, you know, sort of continuing to add interventions like dialysis wouldn't help accomplish her goals. And we sort of had this 30-second conversation right outside, and he's like, oh yeah, like, that's great. Like, we would never do dialysis. And so it wasn't sort of exactly that, but it was kind of picking up off something. He had really taken this thing like, well, if she needs dialysis, she needs it. And then we were able to create a little bit of space about what it means for the kidneys to stop working. He realized that means the care that we were hoping to sort of quickly turn things around wasn't working. and sort of was easily able to see that, dialysis wasn't going to be, part of the framework.
Thank you. That's helpful.
Thank you so much, Jackie. This was really fun. I love talking about language. So, and we all, it's a very important part of what we all do. So this was really brought up a lot of really good questions and answers and all that good stuff. So thank you so much.
Yeah, thanks for having, this was a great discussion. And so I'm so glad to hear all of these points. You guys bring up a lot of really great stuff to think about.
Awesome. Have a good day, everybody.
All right, thank you.
Thank you.